Fluid responsiveness is a physiological condition where increase in preload induced by a fluid bolus leads to increase in cardiac output by more than 10 to 15%. Now we'll have an interesting and interactive panel discussion. The topic is evaluation of fluid responsiveness. Which index for which setting? I invite Dr. Anish Joshi as the moderator for panel discussion. Dr. Anish Joshi is Senior Consultant Intensivist. He's MD FNB Critical Care Medicine and he's presently at Narayana Hrudayalaya Hospital, Ahmedabad. Panelists for this session are Dr. Srinivas Samavedam. Sir is Head of the Department of Critical Care and Medical Director, Viranchi Hospital, Hyderabad. He is also Vice President ISCCM and Associate Editor IJCCM. We welcome you, sir. Then I call upon Dr. Vishal Sadatia. He is Consultant Intensivist and Physician, Shri Giriraj Hospital, Rajkot. Third panelist is Dr. Purvesh Umarania. He is Consultant Intensivist, Bhailal Amin Hospital, Vadodara.
Hello.
Please, sir, have seat on the dais. Fourth panelist, we have Dr. Arul Shukla, Consultant and Head, Critical Care, Shalby Hospital, Surat. Welcome, sir. I request Dr. Anish Joshi to proceed.
Good morning all. It would be a good interactive session. You have the distinguished faculty. They have been introduced. So without wasting much time, we'll be proceeding because this is the commonest question that we are having in our mind. Okay, if there is a drop in the blood pressure or the urine output, what should we do? Should we give fluid or not? So let's see after this session how much we gain from this our esteemed panelist. So my first question to the panel would be, which patient needs a fluid challenge? When we talk about fluid challenge, so what would you recommend, sir?
Whatever we attempt later on, whether you use vasopressors, whether you inotropes, whatever we use, they are all dependent on whether your tank is full or not. So it's not that everybody will get that golden figure of 30 ml per kilogram body weight of fluid, but every patient who has signs of hypoperfusion initially should be, the first question we need to ask is, will he need a fluid challenge? How much we give is a different part of the answer that we can debate, but my understanding is every patient should be eligible for assessment at least for whether he needs a fluid challenge or not.
Okay. What do you mean by fluid? I have given you three options, but it's a MCQ of thing. Whether it's a output that you are seeing, you're looking at blood pressure, or you are looking for something else.
My understanding about fluid responsiveness is it's neither an increase in cardiac output nor an increase in blood pressure, but an improvement in perfusion. That is what is my understanding about, is my patient fluid responsive. The reason is we are looking at one aspect of hemodynamic system. We are looking at a pressure, either we are looking at mean arterial pressure or some other pressure, and then we are trying to give volume at the right side of the heart. You are filling up the right side of the heart, you are expecting the left side to respond by increasing your blood pressure or increasing your cardiac output. Both are functions of the left side of the heart. Your interventions are directed at the right side of the heart. So that's not going to answer the question. So my answer would be, when a patient responds to fluid, the perfusion should get better. This is my answer.
Hello. Anyone wants to add to this?
I think I agree with that. I think, see, as we have understood from first slide also, that who needs fluid challenge means the patient who has a signs of hypoperfusion. So obviously the beginning point also should be the end point, right? When we begin fluid challenge for patients who have signs of hypoperfusion, the endpoint also to see that changes in hypoperfusion, it means improvement in hypoperfusion.
So the thing is that don't target only the blood pressure and go on giving fluids. That is the take home. Now this is about the fluid challenge. What is the quantity and the speed of fluids that one should give as a fluid challenge? And which type of fluid, whether crystal or colloids, what are the scientific evidence behind this, over what time, and something about mini fluid challenge.
So I think uh, we all have understood now, and by this time enough evidence is accumulated that colloids in large volume, I would say, is harmful. I mean, small volume of 250 500 ml may not be that much, but in large volume it may be harmful. So whenever we use fluid challenge, it should be with crystalloids only. Balanced salt solution is preferable. Important point here is about timing. We need to finish off the volume of around 500 ml in over 5 to 10 minutes, not more than that. Otherwise it will not be termed as fluid challenge, right? Otherwise it will be fluid bolus or a fluid resuscitation. But when you want to measure the response to fluid, it should be over not more than 10 minutes.
And what is this mini fluid challenge, and how do you give the fluids in mini fluid challenge?
Again, mini fluid challenge is there are as routinely we give 500 ml over 10 minutes, but in mini fluid challenge we use just 200 ml of fluid given over 2 to 3 minutes.
So is there any rationale of giving a mini fluid challenge, or it does not have much rationale?
I don't think that it changes much, because whenever we see the response to fluid challenge, we want to see the change in the cardiac output with that. And when we measure the surrogates of improvement in cardiac output, generally we see that the changes happens with the larger volumes.
Right. So the commonest test that we do in our ICUs is this passive leg raising. So anyone can elaborate about passive leg raising, how to do, and the pros and cons of that?
Uh, Thank you, Anish bhai. First, I want to add one thing in Dr. Purve's talk. There was one terminology came in the light. It's a troll. So in 2007, it's type of fluid for the fluid challenge, rate of fluid, objective, and limitations. So as you told that the type of fluid, definitely since last decade, there is no doubt that crystalloid is a preferable fluid for the fluid challenge to see the fluid responsiveness, because lots of trials has come out. Second thing is the time and amount. Almost 500 of fluid, 500 ml of fluid over 10 to 20 minutes is the ideal choice or rational choice, because after 1 minute your fluid responsive won't be there. And the last question was the PLR. Passive leg rising test is one of the useful tests in our ICU if the condition permit or clinical scenario permits. That is the ideal non-invasive test to check the fluid responsiveness in the patient, where we can perform this test in a semi-recumbent position, and will must have continuous cardiac output monitoring. Real-time cardiac output monitoring is must in this, because we cannot check spot cardiac output in this. So we can elevate the leg end up to 45 degree, and we can again check the change in the cardiac output responsiveness. If it is more than 15%, raise in the 15%, that is the patient to whom you can give the fluid challenge or fluid resuscitation.
I think rather than mini fluid challenge, it should be termed as a reversible fluid challenge, right? We are not introducing fluids from the outside, we are just mobilizing our own volume.
Very basic question. What are the clinical predictors or signs of fluid responsiveness when you are not having any gadgets and you are taking rounds? So how can you judge about fluid responsiveness?
Yeah. So apart from the heart rate, I think the first thing we see is there could be tachycardia. Whenever there is hypoperfusion, there could be a hypotension, there could be irritability clinically of the patient. The patient may not seem comfortable. He may be irritable, complaining something or the other. The peripherals may be cool, clammy, cold whenever we touch. That is what we do routinely in clinical rounds. We always touch the feet of the patient to know what is the, it indirectly tells us what is the cardiac output and is the patient going into shock or not?
Fine. See, there are two things that they have recommended. One is the capillary refill time. If it is more than 5 seconds, the patient is generally getting hypoperfuse. And second is the mottling score, in which they have seen that it is given a grading. That the first is near the uh, knee joint and means near the patella, and as you go more bigger, the chances that this patient would be fluid responsive are much higher. Uh, so now we'll be going to our main talks, that is whether static versus dynamic parameters. Which would you like to prefer, Dr. Srinivas? Tough questions to you.
Well, if we accept that circulation is a dynamic event, and if you want to stop it from becoming static, you need to use dynamic parameters.
Yeah,
Once it
dynamic is
becomes
always preferred. So
yeah.
we'll discuss out what is static and what is dynamic. Uh, these are some of the preload measures like filling pressures like CVP, the pulmonary capillary wedge pressures, the volumes like LV endastolic, right ventricular endastolic, vena cava diameters, right atrial pressures. So any specific choice from this if you want, though we don't prefer much because of these are static, but any specific or pros and cons of any particular?
See, there are clinical situations where each one of these tests will come into the picture as part of your supportive investigations for your diagnosis and your judgment. But as an isolated standalone tool, none of these are clear determinants of volume status or hypovolemia of a patient. Uh, CVP, yes, there have been a lot of people who have fought against and for CVP, but if you look at its response to fluid challenge or fluid therapy or hypovolemia, it is a highly unpredictable tool. It is coming back into the ICU as a marker of response of the hemodynamic system to PEEP, but it as a tool to identify hypovolemia or to assure you that your patient is adequately filled, it's a misleading variable.
Right.
If,
So as a CVP for giving fluids, preferably avoid doing that because there are multiple caveats and multiple things. So avoid CVP and guide your fluid challenge. Is pulmonary capillary wedge pressure obsolete or still it has some role in certain sets of patients? Anyone?
it is not obsolete. Even today, when you look at any hemodynamic tool that is released into the market, they still compare it with the pulmonary artery catheter and its derived parameters. It's not an obsolete tool, it's a physiologically robust tool. But again, like all other interventions, what you act while interpreting it is what makes the difference and in what context.
Fine. Dr. Srikanth has already discussed about this IVC, but little bit throwing back again. What respiratory variation of IVC and any problems or where you cannot do this measurement of IVC in which set of patients, and same for superior vena cava. Anyone?
In routine, as a non-invasive hemodynamic monitoring parameter, we are using ultrasonography machine in our ICU, and we are having lots of mixed patient, like septic patient, cardiac patient. Some patients are with severe ARDS on mechanical ventilation with high PEEP. If we are using only IVC diameter as an index for hemodynamic instability, that is not a correct answer, because when there is intrathoracic pressure high or when the patient is on high PEEP, we cannot rightly diagnose hemodynamic status of the patient with only diameter. So it's a static parameter, but yes, collapsibility index is somewhat like that to nullify that part. If our patient is on mechanical ventilation and we want to check our hemodynamic status of the patient, we can go with distensibility index rather checking just the diameter of IVC, or we can check the collapsibility index to nullify the effect of respiratory variation in spontaneously breathing patient. So we can improvise our diagnostic markers in non-invasive tools also.
Fine. Another problem with IVC collapsibility is if there is a patient is having intra-abdominal hypertension, then this would be giving us false reading. So keep that in mind. Inspiratory fall in the right atrial pressure, how much it is used in clinical practice?
I don't think, I think we are using it much inspiratory fall in right atrial pressure, because see, I mean, it has been very well studied, and the inspiratory fall in right atrial pressure is told to be correlating very well with the fluid responsiveness, but the amount of change is 1 centimeter or 2 centimeter of H2. I don't
Yeah,
think we have eyes to see that very often.
right. So, what would you like to look at? Whether it's a preload dependence or the preload measures, and what would be the response to fluid challenge particularly? So, what is your preference from these two?
Philosophical question, but I think preload dependence is more useful, right? Preload measures, yes, is to measure the preload dependence, right?
Yeah,
So I think I would reframe the question, but we want to see the preload dependence in patients who are showing the signs of hypoperfusion. Sorry.
okay. So, these are some of the parameters. I will put them like non-invasive static parameters versus invasive static parameters. And these are the dynamic parameters. Greens are non-invasive, majority are on echo and oximetry, and invasive dynamic parameters. We'll talk little bit on this part. So this is all SPV, systolic pressure variation, pulse pressure variation, delta up, delta down. So these are some of the questions for you. In which setting would you like to use? Limitations, effects of tidal volume, and are they validated in larger studies?
Um, I feel SPV PPV is still what we use nowadays, and still we do use it routinely. But the only issue is that the patient should be ventilated, mechanically ventilated. So that is the caveat, that is the problem. In spontaneous ventilated patients, again, there is variability, and even there could be dysrhythmias and all that also, which in which SPVPV does not help us.
Hmm.
Effect of tidal volume, again, a recent, I just went through article with Dr. Sheila Mehta, that tidal volume, when we increase the tidal volume to 6 ml to 8 ml.
That will take. That is the slides
Okay.
there.
Right, right. Okay, okay. Thank you.
Anyone else who would like to add anything?
Uh, as your question is which one is superior, that is a big debatable question. As we all know that previously we were relying on CVP and PCWP. Now someone has said that they are just a marker of preload, they are not the marker of responsiveness. So we come ahead and we came up with SPV, PPV and SVV index. There are certain limitations on that parameters also, so we come upon the PLR test. They are just nullifying their disadvantages, but what is the issue is each and every test having their own limitations.
Yeah.
PPV, SPV, yes, definitely they are the good reliable markers because they are having less disadvantage as compared to other one, or less hurdles to measure it. Definitely PPV and SPV we cannot measure if our patients are having irregular heart rates, if patients are having some issues with aortic outflow tract obstruction and all these things. So we need to think about that. Even if we are using SVV with PVV, definitely as compared to PICO and LITCO, they are having less digitally advanced monitor requirement and all these things we can use easily. But they are definitely superior to CVP and PCWP in our scenario.
Right. Uh, yeah.
So when we use all these parameters, we need to look at against in what cohort of patients have these parameters been validated. If you look at your routine general intensive care patient seen in most tertiary care hospitals, they are already partially resuscitated patients with some kind of extravascular lung water who need to be ventilated with a lung protective ventilatory strategy at a PEEP of between 10 to 12 centimeters of water, and whose rhythms are usually not stable. So we need to go back and look at the literature and see if somebody has validated a pulse pressure variation, if somebody has validated a systolic pressure variation or a delta up or delta down, again in what cohort of patients have you validated? It is this cohort. You cannot bring a parameter which has been validated in elective perioperative patients and shown as a reliable tool for assessment of hemodynamic optimization, bring it to the bedside of a tertiary care ICU for an ARDS patient, in septic shock who's being ventilated and say I will use this parameter, you will end up actually doing more harm to the patient.
Something about this stroke volume variation. What are the prerequisites and any shortfalls for this?
I think it is already been told that prerequisites, I think patient should be ventilated with more than or equal to 8 ml per kg of tidal volume. Now we are actually ventilating patients with 6 ml of kg. I mean, for ARDS patients, not all, but you can increase tidal volume for shorter periods. Another prerequisite is to have, I mean, patient should have arterial line in situ. Otherwise, this, I mean, measurement is not possible. And the patient should not have arrhythmia. Again, otherwise, there will be some false measurements.
We are running short of time, so we'll take these certain slides fast. Something about PICO. I'll not go in detail because of shortage of time. So which settings or set of patients would you like to use, and advantages and disadvantages over other monitoring techniques?
This is something which gives a most important indicator which everybody now is bothered about, is about over resuscitating patients. So to avoid tipping your patients into that positive balanced state, this is something that will tell you by giving you the extravascular lung water index and the extravascular lung water. Experts like Srikanth may actually do an ultrasound and say if this is the profile, then the extravascular lung water is like this. But to quantify it, it's an excellent tool to identify extravascular lung water. Therefore, while ventilating patients with ARDS who also need hemodynamic optimization, this may be the better tool amongst what we have at this point of time, although a little more invasive than what we have at this point of time.
I will, this is the, I mean, all-rounder amongst all the instruments we have. It will not only tell you about the fluid responsiveness, it will tell you about the cardiac output, it will tell you about the fluid overload also, as well as it will actually help in differentiating between different types of shock.
Right. Echo I'm skipping because already Dr. Srikanth has talked. Tidal volume challenge test. There are 3-4 slides now. Tidal volume challenge test. How would you do, and what are the cutoffs?
I think, see, we routinely ventilate patients with 6 ml per kg of predicted body volume. What is the prerequisite amongst the dynamic parameters or is the respiratory variation? When tidal volume is low, the variation in volume, intrathoracic volume will be low. So what we do is we increase the tidal volume to 8 ml per kg for 1 minute, and then we measure the variation in stroke volume or pulse pressure with cardiac index. And if the increase of cardiac index or pulse pressure or stroke volume variation is there, pulse pressure variation more than 3.5% and stroke volume variation more than 2.5%, it accurately predicts the fluid responsiveness, more than 90% accuracy.
Yeah. Something about end expiratory occlusion test, how to do, and any problems with this test?
Regarding the end expiratory occlusion test, in general, the variation of respiration is taken off in an end expiratory occlusion test. So you do the test, you do the measurement when there is an expiration during mechanical ventilation, and that would give it would be like a small fluid challenge. It happens like that, and problems. The patient has to be ventilated. Unfortunately, that is the biggest problem.
There is something what they also come up with is doing a CPAP for 30 seconds for 30 centimeters of water. That is also they have validated and try to prove that these patients are fluid responsive. It is just like an end expiratory occlusion test. A few 1 or 2 lines about carotid Doppler and brachial artery peak flow velocity variation. Anyone?
There's a lot of variation where you do carotid Doppler and brachial artery peak velocity. It is again something very similar to your VTI and your other velocities. So there is a lot of ethnic and racial variation again in these, unless your population has had a baseline. You know, when you say that somebody has got a heart rate of 60, a systolic pressure of 120, a diastolic of 80, and a mean arterial pressure of 65, in such patients of South Asian origin, this is the brachial artery peak velocity. You cannot extrapolate the data and put it into our cohorts.
Last slide of today's panel. Plethysmography variability. easily tool seen in the ICU. Any comments on this?
I think this needs separate device, right? But we all use plethysmography bedside, and I think just by having a look at the waveform, you can understand that this patient may respond to fluid if required.
Right. Uh, Thank you all. We are closing down here. So remember, in ICU, whenever you are giving fluids, see that you don't do more harm. Otherwise, you will fall. Right. Thank you, the panelists, and thank you, organizers.
Thank you, Dr. Anish sir. Thank you, all the panelists. Take home messages: do no harm. At the end of this session on circulatory support, we'll have short quiz session. But before that, we have an announcement. Today we'll be having one special event in the scientific program. It is session number 6 called Man Ki Baat from 4:10 p.m. to 4:50 p.m. It's like just ask me anything, Jama, and you'll get the answer. One can put chit containing the question in the chit box which is kept near the registration counter. And your answers will be given in session 6.